Okay, Dr. Lola. Well, I just want to welcome you to today's session for the Medina Clinic medical education series. So it's medical education series, not medical students. So today's topic is cultural competence. And so there are many topics within family medicine that are, I believe, very important, both clinical and non-clinical. There are a lot of non-clinical topics that are related to behavioral competencies, things related to community health, things related to interpersonal communication that I believe are very critical for the success of a family physician and really for a physician in general. So I would encourage you, Dr. Lola, to take a look at our education series that's on our YouTube channel for the Medina Clinic. You can see past sessions that are similar to this that are on other topics. So today's, again, topic is cultural competence. And so we'll look forward to talking about this topic in terms of how it applies to to our day-to-day practice of medicine.
Okay.
So any questions at all before we start?
No.
All right, sounds good. All right, so let me make sure we have our materials set up here. And again, I'll just mention something about the Medina Clinic. The Medina Clinic is a not-for-profit charitable organization, and its mission is two things. One is to provide charitable medical care to the underserved patients in the greater Kansas City metropolitan area and beyond, and also to provide opportunities for professional development and advancement, to provide opportunities for individuals to learn and get clinical experience, in addition to other professional development opportunities so that individuals can match into residency. So those are really the two goals that make up the mission of the Medina Clinic.
Okay.
All right, super. And let's go ahead and Dr. Lola, I'll just mention that, I was wondering if maybe you could share what medical school that you're coming from.
No.
Oh, okay. All right. All right, Dr. Lola. So let's go ahead and let's move on to this slide here. All right. So basically what we have is this actually, before we go into the different cases, this is a sample from our patient satisfaction survey at the organization where I work. And what we see is this is patient satisfaction by language. So we're able to get this information. And when you look at different levels of patient satisfaction by language, this gives us an insight into cultural competency at our organization. So what we see here is you have a number of the most common languages that we see. And Dr. Lola, tell me, what sticks out at you when you look at these numbers?
I can see that very few people speak Arabic. Am I correct? I can see that the Arabic part is 14.3%, and for the first column, and it's 21.4 for the second column. Then I noticed that a lot of people are fluent in French and Portuguese as well.
Right.
Picking that from the percentages, the 100%.
And maybe I should clarify what the percentages are. I think that would be helpful. So basically, this is a little bit about patient satisfaction, which is very important in medicine. The top, so when it says top box trend, a question is, well, what does that mean? What does top box mean? So, if someone were to rate us on a score of 1 to 5, 5 is very satisfied, and then 1 is very dissatisfied. The 5, if someone rates us as a 5, that's what we call top box rating. So we want to know what percentage of patients rate us as a 5, which is very satisfied or very likely to recommend, for example. So that's what top box means, is the percentage of people that rate us a 5. And if we look at overall, oh, excuse me, I want to mess up my slide here. So overall is right here. It's about 80%. The last quarter of 20, there's the last quarter of fiscal year 2022, and then this immediate past quarter. So it's about 80%, or a little bit under 80% give us a 5. Now, now these are all the percentages of these patients who will give us a 5. As we can see, you appropriately pointed out Arabic speaking patients. Not very many Arabic speaking patients rated us as a 5 at all. Whereas if you look at French, Portuguese, and Spanish, my goodness, almost all of them rated us as a 5. And if we look at, Spanish, maybe not almost all, but 87%, much more than our average. Other percentages that were below average were Russian and sign language, actually. So this tells us that, this gives us a hint as to whether, is there an opportunity for us to have more, because remember what the topic is, more cultural competence for these particular patients. And language is a very important, aspect of cultural competence. So if you were to look at these, Dr. Lola, what conclusions, what conclusions could you potentially make from this data?
Okay, so having a clearer perspective of this now, I'm thinking that maybe language barrier, like during their visit clinic, or when they are communicating with the physicians or the care providers, they are able to understand more, they're able to communicate better in Portuguese and French, and that way they're able to they're able to have more satisfaction, because when you speak the language, they understand you more. So particularly looking at the French, the Portuguese, and the Spanish. But for the other languages, if for whatever reason they don't understand you, they are not able to communicate and understand what you're trying to do for them, then maybe because the cultural differences too exist, and that underscores the kind of care you give them if they don't understand you and you don't understand them more. And that may buttress the importance of an interpreter that understands the languages. And during clinic, if maybe that could improve the percentages, the score, if someone gets a professional interpreter. I don't know if what I'm saying makes any sense, but that's what I understand from all this.
Yeah, absolutely. No, those are all very valid points, and I agree. So good. Well, let's move on to our first case. Okay, now for full disclosure, these cases are derived from Swanson's Family Medicine Review. So that's where these cases are from. That's where the questions are from. And we will review the answers together after we, together try to answer the questions. And then we can talk about why we answer the questions the way we did based on our experience. And then we'll review what the actual answers are. Another benefit to this format is it actually helps with test taking skills. So we can actually, when we discuss our rationale for picking certain answers, test taking skills can be a part of this as well. So let's review the first case here. So battering is battering, or is it? So a 27-year-old African-American woman comes to the office to seek care for a badly sprained wrist. When asked about the mechanism of injury, she indicated she had fallen. However, when questioned further, she admitted that she was the victim of spousal abuse. She indicated that she did not call the police because she was afraid they would not arrest her husband. Okay, so that's the case. So let's look at the first question here. So oftentimes when you see these patients, there are, resources that you can offer them. And one of them is to go to a shelter. And, at where I practice at my organization, there is a shelter that we actually go to once a month, actually. And we have a clinic there where we'll see mostly women, but sometimes men also. So it's important wherever you practice, given that domestic violence, and actually that was another topic that we covered in another, during another session, was domestic violence or intimate partner violence. Given the significant prevalence of this issue, it's important to have a resource available, or to know where your local shelter is in case you do encounter this situation. And what's interesting here is that you have an intersection of a couple topics, domestic violence and then cultural competence in this case. But in any event, her reasons for not choosing to go to the shelter, okay, because many patients will decline to, take it to use that resource, likely included which of the following? So doctor, what, go ahead and let me ask you, what do you think would be the answer here?
Going through all the options, I think all of the above.
Okay.
Yeah. I know there's a lot of awareness right now about people of color feeling helpless, not having the privileged opportunities like the other races, and some not having the privileged standard of living, and some also undergoing a lot of domestic violence, which goes unattended to for so long because they feel prejudiced, or they're not getting the or they won't get the adequate attention they need because of their color. That has been in the media for so long, and so that's looking at through all the options. I think all of the above would fit perfectly into it.
Okay, gotcha. So yeah, you did a great job going through the different points, and I think that if they were unlikely, if they're unlikely to be persons of color working at the shelter, absolutely. I mean, I think that would definitely play into it, and that's where the composition of the staff is a very important factor in how well your organization is culturally competent. She's been there before. That could very well be, maybe she was there before, and they were not sensitive to food preferences and personal hygiene needs, and these really speak to culture a lot of times. So absolutely, I think I think that certainly makes sense, and automatically A and B makes sense. So all of the above is really looking like an attractive option already. So I think I agree. Professional staff are perceived to be judgmental about individuals who have been helpless. So, again, this talks about the staff, not just the diversity of the staff, but also the attitudes of the staff. And that's, that's certainly an important factor as well. African American women have a distinct mistrust of standardized social service agencies. Yeah, you know, I would actually share a personal experience with this. I think so. Once when I was a kid, actually, we had. Hopefully I remember this correctly. It was a while ago, but when I was a kid, we actually had, let's see, social services come to our house
Mm.
almost like to do an investigation, actually. Yeah, yeah. And I think it was because why? I think one of my siblings was and going to school, and I want to say she was either at the time my sister was either in middle school or middle school or high school.
Mm.
And literally, I'm not joking, social services was called to come to visit our house, actually. Now, I'll be now my parents are wonderful parents, they took really good care of us and things like that. And it was really kind of a surprise, why would social services be called to come to visit our home? And I think it's, and I think, probably what was happening was, so my parents are immigrants, okay? And there's a lot of cultural things that, they're kind of getting used to, especially as they're raising kids up in the United States. And, for what, and, I think my sister was talking about things we're allowed to do, not allowed to do. And for whatever reason, this alarmed our the teachers, apparently.
Mm.
And I have no idea what it was exactly, and I'll probably never know. But no, they came to visit, and they sort of checked our house out, and my parents, they're very educated people, like they're wonderful parents, right? And so I don't know, they came and they interviewed my other siblings. Actually, I wasn't there. I think I was in college at the time is what it was. And so I wasn't there. And then it turned out to be okay. So this left a deep-seated, you don't get me wrong, especially as a medical person now, I appreciate the services that these agencies provide. There's no doubt.
Yeah.
And but you can see how, if you're from a different culture and other people don't understand your culture or you don't understand theirs, and then these agencies get involved, it leaves a deep-seated mistrust of these agencies. So so you can imagine individuals that are different cultural subsegments in our society, how this these experiences can breed that kind of mistrust. So that's just one experience that I have. I don't know, doctor, if you've seen anything similar to this story in any of patients that you've seen.
Oh, yes. Well, not personally, but from what you said, I can understand how a little bit annoyed your parent might have been and how
Right.
disturbing it would have been. Them trying to explain to you what was going on and them trying to are you guys questioning my parenting or our
Right.
cultural beliefs? Yes.
Have you seen
I
this in
understand.
any patients you've taken care of in the past? Situations like that?
Yes, so I've seen patients express their distrust and maybe not the health particularly, but with security, how they've been victimized based on their color. Um, Personally, I am quite open, I don't let such things get to me. So maybe I wouldn't say I'm not sensitive, but um even when it happens, I just push it off, because it does more hurt if you actually pay attention, more attention, and you sensitize over sensitize yourself. But I've seen people who are hurting because of all these that you've said, how they've been victimized and how the family members have been victimized and all that. Yeah, so I agree with you.
Yeah, and you know, it's interesting. So at my organization, we have a large Hispanic population. And so my organization is a community health center that takes care of the underserved as part of the safety net in our area. And basically, if you know, the thing about community health centers is that they offer appointments and services on a sliding scale fee if a patient does not have insurance. And part of enrolling a patient in the sliding scale fee is getting information like your W-2s and evidence of income and other documentation to enroll someone in the slide so that you can charge the patient a discounted fee for appointments and procedures and things like that. And so there was a concern amongst the Hispanic population that if they provided information, that information may somehow be used against them by immigration authorities. And so patients were not forthcoming in providing that information. And that was a barrier. It was actually a barrier to providing care to them. A lot of our staff are bilingual in English and Spanish, and that's where the diversity of the staff comes into play to help earn the trust of patients so that you can better take care of them.
True. Very true.
Well, I think let's take a look at the answer, shall we?
Yes.
All right. So number one, I would agree with you. I would pick E as well. So the answer is indeed E. So let me just read off the information here.
Okay.
Studies show that lack of sensitivity to the cultures of individuals who might use the resources makes the resource less acceptable. Okay. Studies have shown that African American women perceive that there are too few women of color working in therapeutic areas and admissions. Often, food and hygiene products are not welcoming and comforting. It is often perceived that African American women are being judged for being in need of shelter. Furthermore, they perceive that the same judgment is not transferred to other ethnicities, which is interesting. Thus, the caregiver needs to try to find shelters, consultants, and other resources of aid that are sensitive to the needs and cultural issues of the African American woman in this case. So,
makes sense.
Makes sense, absolutely. All right. So let's move on to our next question. Now, our patient indicated that she was not willing to report the abusive situation because, is it A, the legal system is often unresponsive to the needs of African American women, B, police are more likely to arrest the abuser in an African American home, C, often the abuse decreases in frequency after a visit by police, D, none of the above, or E, all of the above. What would you say?
Oh, yes. So I agree with A.
Okay.
Yeah, although I think
yes,
well, that might be like we discussed, the awareness is getting more now, but I think before, and then maybe this might vary from state to state. I think the legal system is less likely to respond to them, even just listening to their accent or their color or something. Well, I don't know, they just feel like maybe it's less important for whatever reason. Then the B, Yes. So because that's also correct. I think African American men are more likely to be arrested, more in this case because of an abuse. Maybe that might even explain the reason why there are so many African American men incarcerated right now, because they are more likely to be arrested. Yeah, because they are perceived to be more aggressive due to drugs, domestic violence, and and so there's a sense of insecurity around them, because of that perception, you know. So now this is even going to be more exaggerated, more now that it's coming from an African American man. And yes, so B2 might be correct. Often they abuse the criticism frequency. Yes, maybe C2 might be correct. C2 is correct. Often they abuse the criticism. So that's because if the woman doesn't get the response she so desires, the abuse might continue and even worsen. At the next time, she might not even get the opportunity. She might be dead. So I think A, B, and C are correct. So I would be going with E.
E, okay, sounds good. Let me take a shot at it now. And I'll preface by saying I have not looked at the answers ahead of time. I'm taking it with you essentially. So that way we can, hear our authentic thoughts together, and then we'll together look at the answer. So let's see. Okay. So the way I usually approach these questions is, I make an assessment. I sort of take each answer and make an assessment on how likely it is to be correct. So I look at A, the legal system is often unresponsive to the needs of African American women. Interesting. Now, the thing is, it sounds true, but I'll be frank, I don't know factually, and any data behind it. So I genuinely don't know that. I could not cite any data to support, if it is true. I think, certainly what I do know are a lot of anecdotes. Okay, that's what I do know. So there are a lot of anecdotes on the news and especially with what's been going on, from a social standpoint in the United States. So it makes you, think that it's certainly plausible. This topic is cultural competence, and it's talking about agencies like us being responsive to the needs of people. So it's plausible. So it's possible. So I'll just put a pin in it. Let me go to B. Police are more likely to arrest the abuser in an African American home. Yeah, again, I don't know. It sounds like it could be true. I would not say it's untrue. But I don't have data to support it. And so A and B are kind of similar to me, and I couldn't quite tell you, if one is more true than another. So that's where I'm at with A and B. C, often the abuse decreases in frequency after a visit by police. That I have doubt about. So now, why do I say that? So what do I know? I know that, for example, now I'm extrapolating a little bit, but like in pregnancy, for example, pregnancy is a time where abuse goes up. So generally stress on a family unit, or stress on, when it comes to intimate partner violence, generally is associated with increased abuse. So I have a lot of doubt on C based on what I know. Now, do I know the actual statistics behind this? I do not. But what I do know gives me doubt about C. So A and B, I like more than C. Now, D says none of the above. Is it none of the above? Well, A and B are plausible. E, is it all of the above? Well, I have doubt about E just because, again, I have doubts about C. So A and B, I like more than C. If A, B, and C were all equally plausible to me, then I would do all of the above. But because they're not, based on what I know, I'm thinking it's either A and B or D. So the question is, if I'm taking a test, which one do I go with? Yeah. Yeah, I mean, do I want to make a distinction between A and B? You know, is one more likely to be correct than the other? You know, now B, if I think about it for a second, you know, when police come, so if I look at this, they can arrest the abuser, but they can also arrest the person calling as well. That's something that I know. Again, this is more anecdotes. Because when the police come, and they can arrest anybody, and what's interesting to me is, well, it's interesting if I look at it in relation to the question. She indicates that she is not willing to report the abusive situation. I would think she would be more unwilling if there was an increased risk of them arresting the person reporting. Do you see what I mean?
Yeah.
So in this case, they're like, I would think she would be, you know, I mean, if we look at the case itself, what it says, she indicated that she did not call the police because she was afraid they would not arrest her husband. You see that?
Okay.
So let's go back to this. So if she's afraid that they would not arrest her husband, B may not make sense, right?
Yes.
So if the police were more likely to arrest the abuser, then I would think she would be more likely to call. So when I look at this in relation to the case, it gives me doubt on B, just logically. So I have doubt on B, I have doubt on C. So I like A more than B, and I like A more than C. So based on that, I would probably go with A.
Okay.
Okay, you ready, doctor?
Yes.
All right, let's see. By the way, there are many of these that I've been wrong on. So let's see where we're at here. All right, number 2 is, woo, A, got it. All right, so let's look at the information, shall we?
Yes.
So anyway, that is how, so that's my thought process in trying to answer this question, all right? By the way, something that I would share with you, doctor, I don't know, do you need to take step 3 in the future?
Yes.
Okay, so one tip I would share is that when you're answering the questions, you don't necessarily have to know the answer to select the correct answer. Does that make sense?
Okay.
So you can look at a question and you can say to yourself, I don't know the answer to this. But that doesn't mean you cannot select the correct one, right?
Yeah.
You can oftentimes arrive at the correct answer based on what you know. Maybe you don't know for sure, but you know something, right? So based on whatever it is that you do know, use it to arrive at the correct answer. And that way you do not have to know the answer 100% in order to select the right one. And I guess the other thing that I would mention is that just remember, you do know something, okay? And just use it to get to the right answer. All right, that's my tip. All right, now let's look at the answer to this. All right, you ready?
Yes.
Oh, by the way, but the more you know, the better, obviously, okay, right? So that's why it's important that we read and we study, because the more you know, right? But just because you don't know doesn't mean you don't know anything. You do know something. So maximize what you do know. And if you do encounter a question, and for whatever reason, if you don't know, just remember you do know something, even if you don't know the full information to answer the question. All right. So the answer here is A. Let's look at the actual, information. So interestingly, police are actually less likely to arrest an abuser in an African American home. Okay. And the abuse is more likely to increase if the police are called, but the abuser is not removed. Perceptions are reported that the legal system seems to expect more violence in the African American community, and thus is more tolerant than they would be of a similar complaint in another home. Therefore, if the caregiver is not sensitive to these concerns, abuse may escalate without social intervention. All right. And I think as a provider seeing patients in clinic, these are concerns that are swirling around in the patient's minds that we may not be aware of. So that's part of cultural competency.
Okay.
Yeah. So the answer here was A. Good. Excellent. You ready for the next case?
Yes, please.
Okay. So the next case is entitled, So You Think You Understand Me. So oh my goodness, excuse me. A third-year medical student is about to participate in her first clinical rotation. She will be doing family medicine in a clinic located in an area of the city with a diverse population. She is excited and knows she will do well because she has done a great deal to prepare for this type of rotation. You can get a hint. Of I don't know what the term is. Like, she knows she's going to do a great job, but you can kind of get a hint of maybe like she's maybe being a little bit naive, I think, in this case, right? Okay. Okay, so first question. Speaking of, let's see, in an area of the city with a diverse population. So you're in Brookline, right?
Mm.
What's interesting? I actually did my master's in Boston. Yes, I actually did my master's in Boston. And I remember for a time I was in, I had some housing in the Roxbury neighborhood for a little bit. Yeah, it was very interesting. It was very interesting. I enjoyed the different parts of the city, actually. So
nice.
Yeah, my wife hated the driving. Yeah, the driving she couldn't take it. Anyways, so which of the following will most enhance her care of her care of a diverse panel of patients? Is it A, working knowledge of Spanish so she can talk with her patients? B, having passed a course that taught her the meaning and content of cultural sensitivity? C, developing an understanding of any given culture requires asking questions about knowledge, values, and philosophy of the patient's culture and the impact of those in the treatment plan. D, having spent a summer in a Honduran village, she has acquired an understanding of different cultures. Or E, she has no biases about skin color, religious belief, or country of origin, so she will have no difficulty providing quality care. So doctor, which one would you choose?
I think I'll go with C.
Okay, and what's your rationale for that?
Well, her inquiring about, so if she's faced with a particular culture, I mean, a particular person from a particular culture, and she inquires and asks about their knowledge,
Mhm.
their values, and the philosophy. It helps her to understand, to have a holistic picture
Mhm.
of the behavior of the person she's talking to.
Mhm.
She's better able to understand them and the perspective of the person she's dealing with. Then looking at the other options, being able to speak Spanish is a little specific because the question said she's dealing with a diverse, and I know that there are so many cultures
Right.
that spans across, so A would be correct. Passing a course doesn't really give you the skills because I passing could just be that you've mastered all the notes and you're able to give them a good score. It doesn't really mean that you have the skill which within you, which goes deeper than just passing it. Spending a summer at the Honduran village is also too specific for me because the question says it's a diverse um, community she's going to be working in. Having no biases about skin color and religious belief or country, it's a good trait, is a good quality,
Uh-huh.
but I don't think it's enough to enhance a care. I think it has to go a little more. I understand that when you're seeing a patient in the clinic, you're studying them, you're studying their attitude, you're listening to them, you're looking at the facial expression, you're asking a lot of questions, you're doing a lot of information gathering, you're taking notes so that you can understand them. And I understand that when patients see that you're taking, are more confident that you're going to give them the best care. So I'll go with C.
See, okay. Yeah, I mean, I think C at first blush looks very good. By the way, if you're crammed for time during an exam and you have to pick an answer without really reading it, if you have no time, C is always a good one to pick. We're always taught that for exam taking. The other thing that makes you sort of suspicious that C is the correct answer is that it's the longest answer. So oftentimes your longest answer can be the correct one. So if you have a very long answer, and especially if it's C, there's a good chance that that's the correct answer. So that's just some, also just some test taking things. Now, what's interesting too is I find the case needs to sort of be lined up or juxtaposed with the answer, with the question and the answer. So it says here that she's excited and she knows she will do well because she has done a great deal to prepare for the rotation. That comment I think is relevant when answering these questions. So when I take a look at A, okay, so if I go through, I think I probably agree, but if I want to go through it too, I'll look at a working knowledge of Spanish, so she can talk with her patients. Will that most enhance her care of a diverse patient panel? So interesting. So this will certainly help. There's no doubt about it. And this is actually a wonderful skill to have. But will it most enhance her care? Maybe. Let's see what the other ones are. But so far, that's a good one. Okay, having passed a course that taught her the meaning and content of cultural sensitivity. So which one is more valuable, working knowledge of Spanish or taking a course about cultural sensitivity? I don't know. I think a working knowledge of Spanish may be more maybe more helpful. So I like A over B. C, developing an understanding of any given culture requires asking questions about knowledge, values, and philosophy of the patient's culture and the impact of those in the treatment plan. To me, C is superior to A. because, you know, A talks about a working knowledge of Spanish, right? It actually doesn't even talk about being fluent in Spanish, just a working knowledge. But C is more encompassing because language is one aspect of cultural competency, but certainly knowledge of the culture, you know, of the values, you know, how much the patient knows, that encompasses many more aspects of cultural competency than just language. So I like C better than A. D, having spent a summer in a Honduran village, he has acquired an understanding of different cultures. I mean, they don't even talk about language here. And this is different cultures. You know, even this statement is not internally consistent. It's just one culture, you know, so I don't know. That C is definitely better than D. And then she has no biases about skin color, religious beliefs. Automatically, for me, you just throw this out. I mean, there's no such thing, you know, to say that someone, or if I were to claim I have no biases, that would be a ridiculous comment to make. I think what you want to do is you want to explore what potential biases you do have and correct them. That's why you need to ask questions. And C is more superior than D because it talks about, you know, especially if you take C and you compare it with the case says, oh, she's very confident she'll do fine. It's almost like there's no humility there. Whereas C talks about, well, actually, you need to ask questions so that you are knowledgeable about the patient's values and, you know, culture and knowledge base.
Yes.
So C, especially when you read the case and you match it up to this page, you know, C looks good. So I'm sure C is the answer. Let's take a look, shall we? All right, number 3 is indeed C.
Nice.
So even if one is knowledgeable about one culture being different from one's own, that does not translate to knowledge or understanding of other cultures. Understanding the vast impact of culture on one's health choices best influences a health provider by teaching him or her to ask questions and to seek to understand values and philosophies that might affect a patient's health decisions. One of the major problems in treating someone with a different language is being less fluent or is being less than fluent in a language. Even with interpreters, a major problem is that errors are made because of minor mistranslations. A course in cultural sensitivity should teach one to ask questions. It is unlikely to teach someone to be sensitive. Okay? Believing that one has no biases is likely to increase the bias impact on decision making because the provider is less likely to heighten his or her sensitivity to any unacknowledged biases. So, okay, doctor, any questions on that?
No, makes sense.
Yeah, I think so. All right. And you know, this sounds basic, but you know, a clinic environment is very busy. A patient care environment is very busy, and you're always on the go and on the move. And honestly, I think it's very easy to not be conscious of these concepts when seeing patients. So it takes practice, is the other thing I would mention.
You're right.
Okay, doctor. Let's go ahead and let's have you read this one. This looks like a you know, a busier question. Let's have you read this question. Take a few minutes to select the answer. I'm going to step out, address something in the office right here. I'm going to do that and I'll be right back. And then we'll see what answer you would like to select.
Perfect.
Okay, thank you. All right, doctor, thank you for that. So what'd you pick? Doctor, are you there?
Yes.
All right.
Yeah, so looking at those options, I think I'll go with F.
F, huh? Okay, sounds good.
Yeah,
All right. And what's your rationale for doing so?
First of all, looking at a question, I have to be careful about the use of except. All of the
Right.
are included on the checklist,
Right.
except B and D. So that means that everything on that means that the items you don't want on the list is the answer. So B says that you expect them to accept to fit into the role of the male and the female and the practices in the United States. So that is not correct.
Okay.
Sorry for the interruption.
Oh, you're fine.
So on the D, you have to consider their background, the socioeconomic and the environmental factors as well.
Right.
You're diagnosing and treating them. Yeah, because there are certain diseases that are more prevalent in some in a population of a particular socioeconomic group. Yeah, and some environmental factors also affect and influence your diagnosis. So I'll be sticking to B and D. Yeah, because for D, you have to consider that you have to take that into perspective when you're considering your diagnosis so that you make the right diagnosis and you give the appropriate treatment. So that's why I'm going with F.
Gotcha. Okay, that makes a lot of sense to me. So I will give it a try. So as she arrives at the clinic, one of her assignments is to assess the cultural sensitivity of the clinic by using the Health Resources and Service Administration checklist for self-assessment. You know, this is a great assignment for a medical student. I'll try and use this in the future. I will say that the Health Resources and Service Administration, or in other words, HRSA, that is the agency that accredits all community health centers in the United States, actually. And you know, they have a list of criteria for what an organization needs to do in order to qualify to become a community health center. And community health centers receive grants funding from HRSA in order to operate and to subsidize the care provided to patients who do not have insurance, because after all, there is no third-party payer to pay for that care. So that is replaced by grant funding from HRSA. So HRSA has many requirements in many different categories. There's standards for for the activities in terms of finance, operations, quality, governance, employee relations, credentialing, and on and on. And so this checklist that is referred to in the question is one example of standards that HRSA has for community health centers like my organization. And so while it did not talk about this particular organization being a community health center, it does show that this HRSA checklist is a well-recognized standard for assessing the cultural competence of an organization. So, so I think that that's significant. And honestly, I think that a community health center is a very common place for third-year medical students like this to do their first rotation. In fact, our organization does just that. We have third-year medical students like this all the time who come in, and we'll give them assignments similar to this. But this one in particular is a good one. I wish I saw this earlier. I would have given it to a medical student had I come across this earlier. Anyway, so let's see. All right, so all of the following things are included on the checklist except, so A, ensuring that printed information disseminated by the practice takes into account the average literacy of the individuals in the practice. Yeah, absolutely. Honestly, it's as if they're talking about a community health center, to be honest. The other name, by the way, for a community health center is a federally qualified health center. And just to mention a little bit more about that, that is an ambulatory primary care organization. As I mentioned, it's geared towards the underserved and uninsured and Medicaid as well. Provides sliding scale fee for patients who don't have insurance. You have enhanced reimbursement for patients who have Medicaid. Basically, yeah, you have, I want to say in between 13 and 1,600 what we call FQHCs, or federally qualified health centers in the United States. Again, ambulatory primary care organizations that provide medical, dental, and behavioral health care. That's essentially what a community health center is. So, all right, so A, I can tell you, absolutely. It's as if they're talking about a community health center. Basically, the printed information needs to be in a language that patients understand and at a literacy level that is appropriate for the practice. So A makes sense to me. I don't think, let's see what the other answers are. I don't think it's A. B, accepting and respecting that on moving to the United States, individuals accept and encourage the full range of male and female roles that American men and women display. Yeah, I mean, that sounds kind of suspicious. I'm trying to understand it though. Accepting and respecting. So this is for who to do, the patient or the organization?
Yeah.
I guess this is for the organization. The question is, as she arrives in the clinic, one of her assignments is to assess the cultural sensitivity of the clinic. All of the following things are included on the checklist accept. So this is, I guess, for the clinic to do. So for the clinic to accept and respect that on moving to the United States, individuals accept and encourage the full range of male and female roles. I don't know, this sounds, I agree with you, this sounds weird. So to encourage the full range of male and female roles that American men and women display, to actively do that on a patient sounds inappropriate. So for example, if a patient, well, let's go to the other ones. I think they're, the other points here are will be important to go through. Ensuring that clinic staff, including students, develop understanding that grief and bereavement are significantly influenced by culture. Absolutely, absolutely. Some may be more reserved than others. D, ensuring that clinic staff, including students, not consider socioeconomic or environmental factors when diagnosing and treating patients. So that's ridiculous. Of course, you're going to consider these factors. That's part of taking care of the whole patient. And as far as their insurance status, for example, I mean, you have to consider that, as that will have a huge impact on patients. And if the patient doesn't have insurance and they have to pay out of pocket, that has a huge impact if you're going to schedule them with a specialist, for example. So D makes no sense. So yeah, B and D, I would agree with you, doctor.
Okay.
It doesn't talk about male and female roles. That might be another question. But for example, if a patient has a certain conception of, what is acceptable for, if a female wants a female only provider, or if she wants to decline an exam, they're not going to actively encourage something against her wishes, for example. So that's what comes to mind with B. Okay. So I would be shocked if F is not the answer. Let's take a look. So number 4 is indeed F. So HRSA has provided a self-assessment checklist to promote cultural and linguistic competency. By taking the self-examination, an individual or as an institution can identify the characteristics that are being done well and continue them. That's a form of quality improvement, as well as identify the areas that could benefit from more improvement. Among those that the agency applauds are knowing the literacy level of the usual patient or user and ensuring that materials provided are at a level that can be effectively used. This would include assessing and acknowledging that some patients may have levels of literacy in their first language different from those in English. Another area addressed in the checklist is the importance of understanding the impact that cultural beliefs have on a variety of illnesses or problems, including grief, mental illness, and physical disabilities. This also blends into the topic of breaking bad news. That's another topic that we covered that is on our YouTube channel. So immigrants to this country do not immediately embrace all of our cultural norms, including male and female roles. Socioeconomic and cultural issues have a substantial impact on disease prevention, and risk factors. So, all right, any questions about that?
No, it's clear.
All right, so let's take a look at this figure right here. This is actually derived from a HRSA document, which includes a very detailed checklist for the competency, for cultural competency of an organization. This figure is sort of like an overview of the different the different areas that the checklist covers. So if we look at the very left, you have the domains. These are the critical areas in which cultural competency should be evident. So the organizational values, governance. So governance, for example, would be, do you have an appropriate mix of board members, right? Do you have a mix of board members with diverse backgrounds? So the composition of a board of directors is relevant. Planning and monitoring evaluation. So maybe when it comes to how you monitor for quality in an organization, do you monitor quality in a way that looks at different groups? One form of that would be what we looked at earlier here, right? So this comes from our patient satisfaction survey. So patient satisfaction goes into a number of areas. And here we have the patient satisfaction broken down by preference of language. So this is one way to get at cultural competency, but you can see we are looking at patient satisfaction from in a way that assesses cultural competency. And that is something that can satisfy, or that's an example of how cultural competency is being demonstrated in our monitoring. Communication. So I would say, when we communicate with patients, our organization, we're able to communicate with our patients by text messaging. In our text messaging system, we are able to translate it into different languages. Okay. Staff development. I actually, in my organization, I hired 2 African-American nurse practitioners. And prior to my coming, I had not seen that we had hired an African-American provider in the past, actually. Not to say that we maybe didn't a long time ago, but I had not seen that. So I'm very proud to have, brought on 2 African-American clinical providers in our organization. So that's staff makeup, but staff development actually may refer to something else. That may refer to like continuing education of our staff to enhance their cultural competency, to increase their knowledge of other cultures, and to enhance their skills when it comes to taking care of patients. And maybe refer to that. Organizational infrastructure. So, we talked about here sign language, right? Sign language, we had a low overall rating. So do we have the proper iPads? Do we have enough iPads where we can get the sign language translator on? Do we have the IT support where the iPads don't break down? We have good internet access. When we use our translation line, do we have the right vendor? Is the translation line easily accessible in the examination room? Things like that. Services and interventions. One related aspect, this isn't cultural competency per se, but it's, I would argue, relevant, is something called trauma-informed care. Is that something, doctor, you've encountered previously?
No.
So trauma-informed care, it's a form of cultural competency in my mind, in the sense that how you deliver care takes into account the past and previous trauma that patients have experienced in the past. For example, the color of the paint in the waiting room, how the exam rooms are oriented, how the chairs are oriented in the waiting room or in the exam room, you know, the degree of privacy that people have when having, you know, the office visits, you know, the manner in which information is delivered to them. The lighting, you know, is the lighting too stimulating? Does it exacerbate stress? You know, for sensitive examinations, are they done in a way that minimizes, you know, PTSD symptoms, perhaps? So I think that trauma-informed care can be very relevant if you're dealing with, for example, perhaps a refugee population, where you know, that is a great example of how cultural competency needs to be demonstrated. So that actually blends in with trauma-informed care. So, you know, so your basic procedures in communicating lab results, communicating bad news, helping patients get set up for referrals, you know, can it be done in a way that mitigates you know, recollections of previous trauma? Procedures, how procedures are done, how they're scheduled, how, you know, the manner in which procedures are done. Behavioral health services, the manner in which they are incorporated into patient care. We do dental, right? That's a procedure. Can we do it in a way that minimizes patients? Maybe they're scared of being claustrophobic. You know, so these are all considerations in the services that we provide, in a way that improves our cultural competency. And again, I think trauma-informed care might be a subcategory of this. So anyway, these are some things that would comprise the HRSA checklist when assessing the organization. Is there anything, doctor, that you feel, is there anything else that you feel, another area of cultural competency? You know, we talked about staff, governance, procedures. Anything else that you feel is an area where cultural competency needs to be demonstrated?
I think it's covered most of what I know.
Is there any experiences with patients that you've had in the past where maybe not because of any actions you took, but maybe the system that the patient was in, that clearly there were deficiencies in the cultural competency of the, you know, in the care that was provided? Can you recall any situations like that?
Yes, maybe religious, but
Sure. Would you like to share that example?
oh yes. So for some religious backgrounds,
Yes.
there are some preferences that are demonstrated by some population. For example, those who are of the Islamic beliefs, the Buddha women, they would prefer to be seen by a female doctor.
Right.
Yes, for their examination, for the healthcare they're trying to assess, they feel more comfortable. Yes, so I think for some of the from my experience, I think that perspective sometimes is not fully acknowledged. Yes, so that's what I
Right.
think. Yeah.
That's very interesting. Would you like to share details of that example, like or one situation of how it was not acknowledged? Like, what did the patient?
So yeah, so when the lady came in, she was in a full regalia. So the first doctor she saw was a man, So she was perceived as being hostile. She wasn't answering all the questions. And they thought she was hostile, okay, until a female practitioner walked into the room, and then she was then able to express herself. She was fair, and then when they had their private time, then she told them the reason why she it it was an ONG clinic. So I mean, then she was then able to express a reservation that she wanted to see a female doctor.
Absolutely. And what happened? So it sounds like she was then it sounds like was able to see the female doctor.
Yeah, so eventually they changed the schedule. So she was able to pick the provider she wanted to. So I think in that scenario, patients should have the liberty to pick the provider they want to see. There should be transparency in that regard, to disclose not just the name, the gender. Yes, when patients are trying to access, and give them the choice to select who they want to see.
Mhm. Right, right. And it sounds like maybe she wasn't able to see the doctor of her choice that day, but she was able to, it sounds like, reschedule.
So they were able to reschedule, and everything was sorted out eventually.
Good. And do you know by chance what the outcome in her care was? Was it a favorable outcome for what she was seeing the
So
provider?
eventually it was, once they were able to identify the problem, the so they were able to solve it. So eventually she was subsequently seen by the provider of her choice. So yes, so for the rest of our appointments, she was scheduled with this female doctor, and things turned out better.
And what medical issue was she suffering from?
So it was pregnancy related. She was pregnant, so she was accessing the antenatal care.
Hmm,
Yes, so that was it.
I
So
see.
it was an ONG clinic. Mhm.
Yeah, and what complication of the pregnancy was it?
So at that time, it was just antenatal care. It wasn't really a problem per se. Yes,
I see.
yes, and yes, it was a prenatal clinic.
Right, right. And that's very significant because, a lack of prenatal care, well, that's, directly associated with poor outcomes. So it sounds like in this case, her ability to, the ability of the organization to respect her, sort of her cultural preferences, because they were able to do that, the patient was able to benefit from the prenatal care, which I'm sure made a difference in her pregnancy,
Yes,
right? Or at least the quality of her care. So absolutely. So that's an excellent example. Thank you for sharing.
sure.
So if we look at our next question here, HRSA, still talking about HRSA, and other public and private agencies have increased their concern with cultural competence because, is it A, patient-physician communication is linked to patient satisfaction? We would reference the patient satisfaction data that we shared at the outset of our session today. So communication is linked to patient satisfaction, adherence to medical instructions, and health outcomes. So things that contribute to poor communication may translate to worse outcomes. Is it B? The United States is becoming more diverse, and clinicians will increasingly see patients with perspectives regarding health that are influenced by varied social and cultural backgrounds. C, improved quality and elimination of disparities have been tied to cultural competence and patient-centered care. D is not supposed to be there. That was a previous topic,
That makes sense.
actually. So actually, let me see if there was a D. Yeah, it's just all of the above. All right, so what would you go with?
So I think I'll go with D.
Yeah, I would certainly agree. You know, A, we just got done more or less talking about. I'll actually share with you an example from my organization. There was a patient who I think was from Syria. So she just came to the United States, and she actually it was a mom and her daughter. The daughter was the patient, and the school district, a staff member from the school district, saw that the child needed to see a pediatrician. And of course, you need to see a pediatrician anyway to get, to get a physical for school and things like that. But there were some, I think, some other concerns that the mother had. And so the staff member of the school district took it upon herself to take the patient and her mom and drive her to our clinic, so that the patient could receive care. Now, the mom was very apprehensive. She did not speak English well. She was very apprehensive. She, the English that she did speak, I mean, she even though she had some English speaking ability, she was still very reserved. You could tell she was tense, not very, she had very closed body language is how it was described. And so when the staff member took the patient and her mom to the clinic, they were fortunate in that our pediatrician spoke Arabic, or she speaks Arabic. So when the mom saw that the pediatrician spoke Arabic, she relaxed, she opened up, and she communicated very effectively with our care team. And that was just a wonderful example on how that ability to communicate effectively with the patient made all the difference in the world in providing good care for that patient and her mom. So, so anyway, I just wanted to share that example.
Thank you.
So when you look at A, that sounds good to me. Communication is linked to patient satisfaction. Absolutely. By the way, if you look at this, so our organization, the majority of our staff know how to speak Spanish. So not surprisingly, Spanish, that is a relative strength of ours. And then you have some of the other Latin languages, French and Portuguese. So it's not surprising that our staff do very well when it comes to Spanish and sort of the other Latin languages. We have that one pediatrician who speaks Arabic, but she's the only, well, I mean, I do too, but she probably speaks Arabic better than I do, actually. So Arabic for me is really my second language, but that's it. I mean, so you have 1.5 people at our organization who speak Arabic, and that's there's nobody else. So not surprisingly, the patient satisfaction here mirrors the staff ability to speak the language. Many people speak Spanish, very few people speak Arabic. Spanish is Spanish speaking patients, higher patient satisfaction. Arabic speaking patients, much lower patient satisfaction. So this mirroring makes intuitive sense. Coming back to our question here, where are we? Here it is. So anyway, so again, linked to patient satisfaction, we have some actual data from our organization to support that. Adherence to medical instructions, absolutely. When it comes to compliance, that's a big deal. And adherence to medical instructions and health outcomes. So things that contribute to poor communication may translate to worse outcomes. I mean, I think that makes sense. Is the United States becoming more diverse? Absolutely. I don't need a lot of hard data for that. We have ample experience to say that that is true. And C, improved quality and elimination of disparities have been tied to cultural competence and patient-centered care. I mean, I think we know enough to say that that's true. So I would agree. So number 5 is indeed D. So if we look at the information here, All of the issues described are contributors to the burgeoning interest in cultural competence. And that's it. There is nothing else on that. That's kind of funny. So number 6. I thought there was going to be a lot more information. No, there's nothing else. That's it. So, okay, number 6. As the student begins to see patients in the clinic, she might encounter cultural differences such as, so doctor, what do you think? Is it A, being non-compliant with medications because the color of the pill is believed to be unlucky? B, refusing treatments because religious beliefs about surgery or transfusions? C, refusing examination because of cultural prohibitions on exposure of the body? D, none of the above. E, all of the above.
Yes, so again, I would go with E. Yes, so I would start with A because being non-compliant with medication because the color of the pill is blue. Okay. Yeah, so I'm not so familiar with color-based beliefs across cultures, but I think some colors of some pills, for example, some pills come in red, some may come in some particular colors that's based on your cultural belief, might just be perceived as a danger or unacceptable or evil.
Right, absolutely.
And that if you take it, it's might mean that you have offended some gods or something. So I think A might be correct. Refusing treatment because of religious beliefs, surgeries, and transfusion. Yes, so the popular one that I come across is the Jehovah's Witnesses reservation concerning transfusion. So I think that makes B also correct. Also C, refusing examination because of cultural prohibitions. Yes, so just like we discussed earlier about your religious inclinations, that might limit the physician's practice, regarding examination of some certain parts of the body, which is considered as private. So yeah, so that makes C correct. So I'll go with all of the above.
Yeah, no, I certainly agree. And as far as the color of the pill, I don't think I've encountered that specifically, but I do see how patients are very cognizant of the color of the pill. In fact, patients are typically more aware of the color than the actual name of the medication. So when talking to patients about their medications, they usually refer to the small pink pill or the light blue pill.
True.
And so forth. So they're very cognizant of that. So it's very plausible that, where it talks about the color of the pill to, and some superstitions regarding it, again, it's very plausible. So I would agree with E. I would be shocked if that weren't the answer. The other topics were tougher, actually. The questions and answers were a little tougher. I feel like this is something that, we have a lot of background information about to do well with these questions. So let me check out the actual answer. So it is indeed E. So as described in Fadiman's book, I'm not sure who that is, Fadiman, Fadiman. So this individual wrote a book called The Spirit Catches You and You Fall Down. Patients' beliefs can have a significant impact on their decision-making. Her patient's family refused medications because of the pill color, believed to be unlucky, and refused spinal taps and surgery secondary to religious beliefs. In other cultures, female patients still point to dolls to describe sites of pain or dysfunction because they are prohibited from disrobing for male physicians. So that's the information there. All right. So next question. We're still with our medical students here. So as the rotation progresses, the student is struck by the frequency with which African American women seem to have breast cancer. When she studies the available data, she finds that African American women continue to have higher rates of mortality from breast cancer than those of white women. She would share majority opinion if she believes, she would share majority opinion if she believes the disparity in the outcome exists because, is it A, many African American women have not received regular mammograms? B, African American women do not breastfeed, so they are at higher risk? Is it C, African American women have larger breasts and are unable to palpate the mass until it is relatively larger? D, African American women are fearful of exposure to the radiation of mammograms, so early detection is unlikely? Or E, African American women have a genetic predisposition to breast cancer? This may be a little bit of a tougher question because it's asking what is the majority opinion as to why African American women have higher mortality from breast cancer. So doctor, what if you were taking this exam, what option would you choose?
Yes, so I agree with you that I found it a little tricky because I really don't know the answer. But if I have to pick one, I would go with A. The reason is because maybe the difficulty in accessing medical care because of the cost. So even just accessing the medical care, some might not be able to afford it. So it's only when you access the medical care that you're able to access a mammogram, and with all the costs that comes with it. So I'll guess A. Yeah.
Gotcha. Okay. Yeah. Yeah. I likewise do not know the answer here. If I look at the question, it says that the medical student is, has realized that there's a difference in mortality. Now, she would have an opinion as to why there is this difference in mortality. So what opinion would she have? And it says here, she would share majority opinion. When it says majority opinion, I admit, I don't know if they're talking about majority of the general population or the medical community. I'm not quite certain. Yeah. So if I look at A, many African American women have not received regular mammograms. That's certainly very plausible. And that was the answer that you chose as well. African American women do not breastfeed, so they are at higher risk. Is that a majority opinion? I don't know about that. I think A makes more sense than B. C, African American women have larger breasts and are unable to palpate the mass. Yeah, so C is sort of, I have some doubt about that to a similar degree with B. So far, yeah, I like A better than B and C. D, African American women are fearful of exposure to the radiation of mammograms, so early detection is unlikely. Well, I've liked A the best so far. So when I compare it with D, they're kind of talking about similar things, it seems like. In A, they have not had regular mammograms. In D, they have not had regular mammograms. I mean, they're fearful of exposure to radiation of mammograms. So D is very specific. I have not heard of this in the past. I have not personally encountered an inordinate fear of radiation specifically. So I have some doubt about D. I think there could be many other reasons why African American women have not received regular mammograms. So potentially, I think A is superior to B, C, and D thus far. African American women have a genetic predisposition to breast cancer. Yeah. Interesting. So, and I'll be honest, yeah. So in terms of answering this question, if you have the medical student if you just picture the medical student coming across this data and says, oh my, look at this difference in mortality. It is significantly higher in African American women. I can see the medical student, especially kind of given the picture of the medical student that was painted earlier, which is that she just thinks she thinks she's going to do great, right? She is prepared well. She knows all about taking care of a diverse population. So maybe she's a little overconfident. And I wonder, in the mind of a third-year medical student, when you first look at this data, maybe that's what you are more likely to come to. You're more likely to come to the answer E, that, oh my, they just must be automatically predisposed, because it sounds like she still has a lot to learn. I'm guessing that this student has a lot to learn about, social determinants of health. So that's how I'm picturing this.
Okay.
What do you think?
Yes, I'm not sure. So
yeah, but I don't know the answer. I mean, I think that if you ask me, I think the answer is probably A. That's probably what it is. I know historically, I will say this. I had a classmate, right, in medical school, and she's from Virginia, and she will be the first to admit she was not exposed to any diverse. She was not exposed to any diverse populations growing up. Okay, and she made a comment to me one time. We were in anatomy class, and in the anatomy course, she actually expressed not shock, but maybe a little surprise that when we were doing the dissection of the cadavers, that the African American, believe it or not, that the African American cadaver was identical to the Caucasian cadaver, if you can believe that.
yeah.
And now, of course, she's the first to say that, obviously, of course it's the same. I mean, why would it be different? But just the way she was conditioned growing up, there was almost like she would not be surprised if there was some sort of racial or difference based on race. Again, she was sort of referencing based on how she was conditioned growing up, on the community she grew up in, and her exposures growing up and so forth. So when she made that comment, it was surprising to me, I think. But of course, that just goes to show each of us need to explore our different biases. So she was a second-year medical student, actually, at that time. So that's the sort of situation that I'm picturing. So I'm wondering, that experience sort of makes me think that maybe the answer is E here.
Okay.
So, okay, so you ready?
Yes.
By the way, doctor, this is the first one where we pick different answers. Oh, no, actually, no, I think we picked different ones before.
Second one, yes.
Yeah, okay. Well, anyway, this is our last question, by the way. So let's see what the answer is. And let's see if we interpreted the question correctly.
Okay.
Number 7. Oh, doctor, you are correct. It is A. Good job. You see that? I read too much into it. I should have just kept it simple. So, well, let's see what the information is, huh? All right. So A, many African American women do not have access to or are not referred for regular mammograms. And this is thought to account for later diagnosis and subsequent higher mortality. However, many physicians and other providers blame other cultural and lifestyle reasons for the disparate numbers. Blame is in quotation marks. Okay, so I clearly did not give the medical student enough credit in this case, right? So we have our answer. So, the logical, the logical conclusion when looking at the data, and when it says majority opinion, I guess it's talking about majority of opinion of the medical community, basically. So I shouldn't have read too much when it says majority opinion. I think I did so a little too much there. So anyway, any questions on this or any thoughts?
No.
Yeah, and there was an opportunity to share this example that I had, or this experience that I had, which again goes to show that we need to explore our biases. Now, when I, in preparation for today's session, when looking at this question, it prompted me to look at our data in our organization that I would like to share with you, which is the mammogram screening rates of African American patients versus Caucasian patients or white. So that is this slide here. So there's a few things that I would point out. White is a race. By the way, there's a difference between race and ethnicity, okay? So when it comes to white and Black / African American, those are races. Ethnicity is Hispanic and non-Hispanic.
Makes sense.
Well, I'm glad it makes sense to you because it took me a little bit of time to get used to. So what's interesting is that you can have someone who has a Hispanic ethnicity, but their race is white, actually.
Yes.
So that's an interesting feature to this. So when looking at our organization, what these graphs show are first of all, it's two graphs. One that is for the our white patient population, and the other is for our Black / African American patient population. These graphs reflect our mammogram screening rates, okay, in these patients. So I would point to this comparison of the actual rates. We see that in the white population, the screening rates amongst white patients is 60%, correct?
Yes.
When we look in our African American population, look at this, it is 49%. Pretty significant difference, right?
Yes.
And what we see, we can turn our attention here is the number of patients. Now we see that white patients outnumber African American patients by like 9 or 10 to 1, or actually 11 to 1. So we have a lot more white patients. Again, actually, a lot of these patients are actually Hispanic, in addition to, other Caucasian. But we see a few differences here. We see a significant difference in the screening rate, 60% versus 50%. We have a difference in the size of the patient population. But let's move on over to the right side of the screen here and look at the network averages. The network averages reflects all the community health centers in our state, in the state of Kansas. My organization is called Health Partnership. We're right here. And this is us in comparison to all the other community health centers or other safety net clinics or community clinics in our state of Kansas.
Okay.
So this is a comparison of how we are with other organizations. Now, you can see that when it comes to the white patient population, we are third in our state. When it comes to African American patients, we are fifth in our state. It's actually not that big of a difference. If you look at, second, third, fourth place here, they're all pretty similar. Here, second, third, fourth, fifth place, it's all pretty similar. So in comparison with our peers, we're kind of in the top half for both white patients and African American patients. And actually, when you look at the network averages for white patients and African American patients, and compare it and look at that gap and compare it with our gap. If we look at our gap, what's the gap here? Like 10%?
Yes.
So let's look at the gap of the average of the network. So the average network mammogram screening rate for white patients is 52%. The average network of breast cancer screening for African American patients is 42%. So the gap here is also 10%. So our gap is 10%, and that mirrors the gap, the overall gap of all the clinics in our state, or all our member clinics in our network in our state. The gap is 10% in each. So one more thing I would point out, we see that our breast cancer screening rates a year ago were going up, and that reflects our efforts to improve our screening rates. Actually, interestingly enough, for whatever reason, and I don't know why, I don't know if it's something to the data, but our breast cancer screening rates of African American patients was actually higher than in white patients a year ago. And interestingly, they both went up, and breast cancer rates in African American patients were consistently higher for a while, actually. But then it dropped off a little bit. And then it looks like in African American patients, it dropped off more precipitously than with white patients. I don't know if that's statistically significant or not. And it dropped off more precipitously, and we're lagging. So it's interesting. A year ago, African American screening rates were actually higher, but now there's a 10% gap. I can't tell you what that's due to. And it makes me wonder, are the interventions, so it raises the question in my mind, are the interventions that we have employed to improve our breast cancer screening, did it have a differential effect on between these two groups of patients? I don't know. That's a question at least worth entertaining. So, I wanted to point out our gap. I wanted to point out the gap of our network, and then to look at our trends. So are there any conclusions, doctor, that you can take away from this performance of my organization?
So I'm also just trying to figure out why there is a reduction and tailing towards the end for the African American at the graph at the bottom.
Right.
So I don't know. I don't know. I want to ask a question. Did you increase the cost of the services being rendered? Was there a price increase? I don't know.
So that is an excellent question. So in our state, just like many states, the state has a program where women who are low income, if they qualify because of their socioeconomic status, they can get mammograms for free. So virtually all our patients who do not have insurance qualify for this program. Of course, if they have insurance, then they are able to get their mammogram because of that. So the cost really has not changed in the past or during this whole time period.
Okay.
Actually, you know what is interesting is that in the past few months, that program ran out of money. so I shouldn't say it hasn't changed. The program ran out of money. And so we've been looking for alternative ways to have those patients get mammograms, but actually the rate has gone up modestly in the past few months.
Okay.
So I guess that program running out of money did not have a bad effect on our screening rates. But to answer your question, that's one of the benefits of being a community health center is that patients who don't have insurance were more easily able to get them access to programs to get their mammograms. So to answer your question, there really is not a difference in the cost itself. Although you bring up a good point, maybe there's a difference in, there's some other aspects of the program that's resulting in a differential. I don't know. And that program that we use, it's a state-run program. So you know what? I don't know. Maybe in our network that there's something about the program that might account for that gap. Now, what's interesting is that this program has done wonders in terms of getting women access to mammograms. And we have diagnosed many breast cancers, including in African-American women, I might add. We have definitely had women take advantage of the services to get diagnosed and to get the care that they need. And so maybe that's a question on the state level. Maybe, maybe there's some aspects about the program itself. I don't know. Yeah.
Okay, thank you.
What other opinions do you have? Like what other thoughts do you have when you look at this, data?
Well, I followed quite well when you said the population of white and the Black or African American, you're saying it's almost on the top half, it's the same when you compare them. I don't really have any additional opinion right now. I'm just still trying to study and understand everything I'm looking at right now.
Yeah. And what's interesting is that oftentimes these things are multifactorial. And, I think what's relevant is that one of the providers that we've hired, I mentioned we hired 2 African-American clinical providers, and one of them is a women's health provider. So, I think that not having a lot of African-American staff historically, that's something that's wonderful to have to have increased diversity. And it's interesting to see if that has any impact on perhaps decreasing this gap of 10% that we have. So that would be interesting to see going forward. Okay, I think we have one more question. So let's see here. So I did not give our medical student enough credit for the last one. So let's try and give her credit here. So as the student begins to see patients with a translator for languages she does not speak, she finds that a short question by her often ends with a lengthy exchange between the translator and the patient. Which of the following describes why this phenomenon occurs? Is it A, this always means that the translator is adding his or her biases to the medical information? B, this often means that the translator is trying to ensure that the patient understands the question or the information being provided? C, this cannot be tolerated because it is impossible to trust the communication that is occurring. Or D, it is important to talk to the translator to ascertain what is being said beyond the question or information provided by the physician or student. Or is it B and D?
Okay. Initially, I chose B. This means that the translator is trying to ensure that the patient understands. Yes, because for me, the English language is very very brief when you compare it with other native languages where you put a lot of description, sometimes some adages, proverbs, and all that. So B is correct to me. But then I saw D, that it's important to talk to the translator to ascertain what has been said. So yeah, so that the medical student has confidence in what the translator is saying, she just needs to clarify from the translator if there are any additional information the translator is adding, if at all, or just to have a clearer understanding of what the translator is communicating with the patient. So I would choose E, B and D.
Yeah, I would probably agree. I think that the translators nowadays, I think they are acutely aware that the providers or the clinical person or the individual of the patient care team is sensitive to when it sounds like there's a conversation between the translator and the patient, and this may raise questions in the clinician's mind, and so translators will preemptively say, "Doctor, I'm just clarifying with the patient," or "Doctor, I'm just making sure that the patient understands," for example. So translators will preemptively say that, knowing that it's pretty clear that there's extra conversation going on. And as the clinician, it is important to ensure that the information received by the patient is correct and appropriate. So sometimes as clinicians, we'll have a hunch that the translation is not exactly what we said. Maybe the translation may not be exactly correct, or we have that impression anyway, or we sense that there's extra conversation. So it's important for us to clarify, if we do get that impression, what information is being provided to the patient. So so for these reasons, I would agree with E. So let's double check our answer here. And it is E. So learning to work with a translator means developing confidence in the process and the need for the translator to ensure that the patient understands the question or the information being provided. Even after patients leave, providers should talk with translators to determine the complexity of the process. Because languages are not translated word for word, sometimes a translation takes longer than the original question. And I think that agrees with what you mentioned, Doctor.
Yeah.
However, ensure that the translator is not inserting his or her own biases. So that is important for the provider to do. All right. Good. So let's look at things in summary. So in summary, cultural competence is the integration and transformation of knowledge about individuals and groups of people into specific standards, policies, practices, and attitudes used in appropriate cultural settings to increase the quality of services, thereby producing better outcomes. The fundamental value of racial and ethnic concordance is improved communication. Okay, so yes. So a couple things I would mention is that the attitudes are very important. So, patients may have, they may make decisions or choices that are rooted in their cultural beliefs. And it's important to respect, to be respectful of those choices and the patient's approaches to things. And so that's why it's important. And so it is important to have a respectful attitude, when it comes to these things. I think sometimes you can get frustrated if a patient, like, for example, they want a female provider, and you get frustrated in the sense of, well, this should have been handled when the patient first scheduled, right? So somehow, this could have been addressed earlier. So instead of being frustrated, an appropriate practice or policy is maybe the receptionist can ask the patient, would you prefer a female provider? Okay.
Mhm.
So you got to have the right attitude and the right policies and practices. And then, of course, the value of racial and ethnic concordance is improved communication. So maybe that's diversity of the staff or just the skills of the providers. There is not a question that communication is improved. By the way, communication is a risk issue in an organization. I should have put that slide on here. Let me see if I can now, actually. Hang on a second. I am very much tempted to put a slide that shows how communication is a real issue when it comes to risk management. Let me see if I can find that. Let me see if I can find that graph. Here we are. Here we are. Okay, bear with me here. I'm going to try and paste a figure or a graph that demonstrates the importance of communication when it comes to risk management.
Okay.
Bear with me. Paste it there. Okay, so this graph actually is a line chart that shows communication and customer service risk events. So we keep track of this. When there is a breakdown in communication, that can result in suboptimal care to the extent where we keep track of this closely. So actually this flat line is during COVID. So during COVID, the volume of patients went down a lot, and that was a crisis time in itself. So actually there were no communication customer service risk events during at least the first 6 months or so of COVID. But before, you see we had an average of about 3 risk events per month, and we worked hard to improve that. Actually, during COVID, we did a number of things. We started using the patient portal to communicate with patients. We started implementing safety huddles in the morning to improve communication between staff, and communication those efforts to improve it resulted in decreased risk events that were related to communication. And so this improves how we perform as far as risk management and decreases the risk of complications and improves the quality of care for our patients. And so when it comes to communication, that is a critical issue. And we can see how cultural competence plays into it. That's why when we go back to patient satisfaction, these are areas of improvement. So, all right. So otherwise, we would say that also in summary, it is demonstrated through the ability of healthcare providers to understand and respond sensitively and effectively to the cultural and linguistic needs of patients. Research suggests that patients in racially concordant relationships are more likely to use needed services and less likely to postpone seeking care. Okay. Excuse me. Often, the difference is not language, but rather the milieu in which the conversation and interpretation occur. So that, talks about like trauma-informed care as an example of one type of, when we talk about milieu, that's like the atmosphere, the surroundings. At times, the interpreter may have to serve as a cultural bridge between patient and caregiver. They may both speak the same language, but come from such varied perspectives that meanings are not clear and misunderstandings occur. The US population is increasing in diversity, so cultural sensitivity is increasing in importance. Evidence suggests that the language of the interview is a significant contributor to the outcome of the interaction. Medical interpreters are a primary addition to the scope of services as our communities become more culturally and racially diverse. The role is to convert one language into another without changing the original meaning, because shared meaning is critical. Medical interaction with individuals whose primary language is different from that of the caregiver often leads to medical mistakes with frequent incorrect translation of words, clinical misdiagnosis, adverse drug reactions, and problems understanding drug labels. We have one clinician who, when she prescribes medications, she puts the instructions in Spanish, as an example. At least one survey suggests that many health providers do not know how to work with interpreters. In 2001, 14 standards related to culturally and linguistically appropriate services in healthcare were created. The standards cover 3 broad areas of requirements in healthcare for racial or ethnic minorities: culturally competent care, language access services, and organizational support for these initiatives. All right, so that does it, Doctor. So I had a real good time reviewing this topic. I felt like we reviewed it pretty well.
Thank you so much. I really had a very informative session. I learned a whole lot.
Wonderful. I did as well. So I think that concludes our session, and I believe, Doctor, we will do this again next Sunday, if I'm not mistaken.
Yes, the same time?
Same time.
Okay, perfect. Thank you.
Thank you, Doctor. You have a great weekend.
You too. Bye.
Bye-bye.